Okay, good afternoon, everyone. It is 12 o'clock, so we will go ahead and get started. So thank you for joining us today. My name is Katrina Hernandez, and I am a behavioral health consultant with OPEN, the Overdose Prevention Engagement Network. Welcome to today's webinar, New Highs, Understanding Cannabis Use in Today's Youth and Young Adults. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, CE, Social Work CE, and MCBAP credits for today's webinar. We will have a slide up with information about obtaining these credits during the Q&A portion of the webinar. And we will also email the continuing education credit information after the webinar today. So the Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect physicians with experts who specialize in prescribing medications for opioid use disorder and managing complex acute care and perioperative pain in the setting of OUD. These physicians can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. All of our webinars offer free CME, CEU, and MCBAP credits. And for prescribers, all of our credits also qualify for the DEA required SUD training. We provide MOUD training for physicians. And this year we are incentivizing primary care providers with $250 to complete one of our MOUD trainings to encourage confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all of these services more directly using these QR codes or visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable education materials for both patients and providers. The patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options by assisting groups across the state and hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants, and we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. For overdose rescue support, we also fund implementation of naloxone vending machines and distribution boxes, naloxone administration training. These trainings are offered as live, virtual, or free online training courses. OPEN understands that effectively addressing OUD and other substance use disorders requires deep collaboration and tailored solutions to meet the unique needs of each part of the state. We continue to provide regionally dedicated behavioral health consultants. Each work directly with physicians, physician groups, and community organizations in your area to help build connections in networks locally. I will now introduce today's speaker. So Dr. Bonar is a licensed clinical psychologist and a professor at the University of Michigan in the Department of Psychiatry. Dr. Bonar received her BS in psychology from Northern Kentucky University and her MA and PhD in clinical psychology from Bowling Green State University. She is a director of research strategy for the Michigan Innovations in Addiction Care through Research and Education program within the Department of Psychiatry at Michigan Medicine. Dr. Boner spends most of her time leading and collaborating on patient-engaged research. She studies ways to prevent and treat substance use disorders and wants to improve how this can be done by using technology-based tools, patient portals, smartphones, internet-based programs. She has particular expertise in cannabis and is the cannabis content expert of the Injury Prevention Center, where she leads reporting on the impacts of recreational cannabis law in Michigan. And I will now turn it over to you, Dr. Boner.
Thank you so much. Are we seeing the correct screen? Can I get a nod, Katrina? You see the title screen?
Yes, looks good.
Yeah, you are good.
Right. Okay, always like to check. Okay, thank you everyone for having me today. I'd be glad to talk with you a little bit about cannabis use in today's youth and young adults, while also noting that we can't really understand the context of cannabis use that young adults and youth are in without also looking into the bigger picture and what's going on in our country. So I'll share some data with you as we go. In terms of disclosures, I have no financial relationships related to this activity. No one really gives me much money to do, anything that might bias my work. But as mentioned, I am in the Michigan Innovations in Addiction Care Research and Education program, which is a group of faculty and clinicians who really care about transforming addiction care in both from the perspective of substance use disorders and from the prevention perspective and cross substances. And so, we're a collaborative group of people who are really working to address this problem. As mentioned, I'm part of the CDC funded Injury Prevention Center. I receive financial support via grants from the NIAAA and NIDA, and I do consulting for a company called Prevention Strategies. The other disclosures that I was asked to include are all of these things about continuing education and accreditation that I won't read to you, but I, again, have no financial stake in anything related to this. Today's presentation, my goals are to help lead to an understanding of the latest epidemiological data on cannabis use among youth and young adults, learn about different types of products, and explore why potency of products is a concern. In case you get interrupted, you tune out or something, my take-home message is that current science really do point to a continued concern about the role of cannabis products in today's society. I want to include here that there are a few resources that anyone can access, and they're sort of my go-to for finding answers about cannabis. This is the National Academy of Sciences report on the health effects of cannabis. This is like a cannabis encyclopedia. In 2016 or so, any study that had been done was summarized here, both from a medical perspective about benefits, but also risks and harms. Cannabis use has really grown like a weed since 2016. And so cannabis use and cannabis use research, I should say. And so they're out in the process of updating this volume, and we hope to see a new one soon. In addition, today, I'll rely heavily on results from the National Survey on Drug Use and Health, which is the NSDA. In 2022, data have come out most recently. So in November, we received data for 2022, which I will be providing a lot of today. In addition, there's this article by Jason Connor. It's just a really great overview, sort of an all you need to know about cannabis and cannabis use disorder. Highly recommend it. Some of my disclaimers I want to give before I jump into this talk are that, unfortunately, in this world, epidemiological data that I'll be showing, the most up-to-date data are a few years old. So our 2022 data came out in 2023. Feels hot off the presses if you are a researcher, but not so hot off the presses if you're living in 2024 and wondering, why can't we get 2024 data? But that is the slowness of research. I also want to note my expertise is in psychology and psychological and behavioral impacts of cannabis and substance use. I am not a physician. I don't really get into physical health effects of THC consumption, medical cannabis, and I'm also not an adolescent psychiatrist, so I don't really treat co-occurring conditions in youth. I just want to give you the limits of my competence here. The other thing I want to note is that we are looking at, in the Injury Prevention Center, the impact of Michigan's recreational law. In 2020, we produced a report that was sort of the before of what different health and well-being indicators look like in Michigan. And we're in the process now of feverishly writing up some after data to see what if any impacts we've seen in the state since legalization in 2019. If you want to be among the first people who know about that report when it comes out, you can sign up for the Injury Center's website newsletter, and you can follow them on Twitter or me on Twitter. And when it's out, you'll know. So just letting you know, be on the lookout for that this year. Okay, now, although some of the data and reports we discussed today will use the term marijuana, I'm going to emphasize that the field's really moving away from this, given the history of marijuana as a term used in Prohibition era propaganda that promoted racism and xenophobia. I'm not going to get into the details here, but if you'd like more information, the Guardian article that is shown on the right has a good breakdown of this issue. And the Library of Congress has some interesting photo gallery to look at in a sort of a timeline. Suffice it to say, I'll be using the term cannabis as much as possible, although you'll see marijuana on my slides because that's still what NSDA uses, and I've drawn a lot of data and information from NSDA. So what is cannabis? It's a broad term for products that come from the cannabis sativa plant, which can include medical, recreational, and other products like industrial products like hemp. For today and our purposes, we're focused on psychoactive formulations of cannabis, specifically those containing the cannabinoid delta-9 THC, which is generally responsible for cannabis intoxication or getting a person high. We won't be discussing CBD products, and I want to clarify that CBD are products that come from cannabis, but they have no or very, very trace amounts of THC. There's a lot of interest in CBD for the therapeutic effects, and it does not produce a euphoria or a high, and it has a low potential for abuse and dependence. I only bring this up to say their key concern around CBD and CBD products right now may be in normalizing the use of cannabis products, especially for youth. And I've highlighted a few studies here by folks, two different researchers, last name Noel, but two different people. One finding that young adults exposed to digital cannabis advertising were more likely to drive under the influence of cannabis. And another that found that adolescents exposed to cannabis advertising in Canada, where they have countrywide legalization, had increased intentions to use cannabis. So we're thinking about some of these different products. I also want to think about just the environmental exposure and what we see around us. In the terms of the big picture, cannabis is the third most common controlled substance used by more than 4% of the population, and that's been increasing over the past decade or so. And there are millions of people worldwide who also suffer from a cannabis use disorder. Shown here, you can see that the majority of the population in the US, ages 12 and older, so inclusive of adolescents, most people don't use drugs. But there are about 61.9 million people in the US who used cannabis in the past year, more so than other drugs that are of concern recently, like prescription opioids and heroin. And I want to show you this breakdown of substances side by side. And I want to note that the data published by NSDA in these figures do not show substances in the same order from top to bottom, with the exception that cannabis is at the top and heroin's at the bottom. The largest proportional increase in consumption of drugs from just 2021 to 2022 was an 18% jump in cannabis use. We went from 52.5 million people using cannabis in 2021 to 61.9 million. And when you look at time trends in the US in general, you can see that among those 12 and older, which is the red triangle line, past year use has been increasing. This has risen from 11% of the population in 2002 to currently about 22% of the population. So about a doubling in prevalence since 2002 over the past 20 years. The blue line at the top is young adults, ages 18 to 25, and adolescent ages 12 to 17 are the grayish line. As showed in this slide, there are some methodology changes in the NSDA data that in 2020 that mean the pre and post-COVID trends, we can't 100% compare them But we now also have a few years of data with post-COVID method changes shown in some of those hollow shapes in the data on the right. And we can see that cannabis use is ticking upward. On those green boxes in the right, you can see that direct side-by-side comparison of 2021 and 2022 data. Every number is just a bit higher than the year before, demonstrating what I see as the formation of a pattern of an increase in cannabis use. And although that gray line for adolescents was trending downward slightly in the early 2000s, the number has been ticking up again since 2020, such that 11.5% of adolescents used cannabis in the past year in 2022. For young adults, that number is more than 3 times greater at 38%. In terms of using cannabis for the first time, in 2022, as shown on the right, 3.7 million people used cannabis for the first time. This is a 42% increase compared to the 2021 data on the left. In 2022, 1.2 million adolescents aged 12 to 17, 1.2 million young adults aged 18 to 25, and 1.3 million adults over 26 initiated cannabis use for the first time. More than half of the 3.7 million people total in 2022 who used cannabis for the first time did so before the age of 21. Now, again, I haven't been able to update this graph on the left yet with recent data, but that is shown instead on the right in the blue table. But over time, you can see that pre-COVID, this number of new initiates of cannabis use was going up for many years, as shown in that red triangle line. The estimates from 2020 suggest that initiation of cannabis use went down in 2020, which is expected due to COVID and methodological changes in how this study was administered at the time. And we would have expected the trend of general increase to resume post early COVID lockdowns, and the data on the right show from 2021 and 2022 that that's really starting to bear that out. So for the general population, again, ages 12 and up, 3.7 million people used cannabis for the first time in 2022. That's about 10,000 people per day, and it's statistically greater than what we saw in 2021. We are seeing that break down to about 1/3 of adolescents, 1/3 young adults, 1/3 adults over age 26. Roughly 3,300 adolescents are using cannabis for the first time each day. Across the board, that translates to about every 8 seconds, someone initiating cannabis use for the first time. Why should we care about that among youth? So this is some slightly older data, and I think we're going to see these numbers change over time, but the median age of onset of cannabis use tends to occur most often in young people. So that median age of onset is 18 or 19. The mean is 15 or 16. And there's a lot of research out there that tells us that, early initiation of substance use and early initiation of cannabis use has risk for later outcomes that people don't particularly want to experience. So, for example, initiation before age 16 increases risk for cannabis use disorder and how quickly one progresses from use to disorder. And there's a study that showed that if a person starts using before age 14, they have 4 times the risk of developing CUD versus someone who starts after the age of 21. So delaying initiation may be effective at reducing risk of cannabis use disorder. We also see that use before the age of 18 confers increased risk for motor vehicle crash, antisociality, polysubstance use, and school dropout or other academic problems. Early initiation is also associated with poorer memory outcomes and lower IQ over time. And in cases of heavy ongoing use, when there's a period of abstinence, that later abstinence does not necessarily restore cognitive functions that were impacted by the long-term cannabis use. Use during adolescence and young adulthood also elevates risk for mood and anxiety disorders, as well as psychotic disorders and schizophrenia among people. So, given all that we know, prevention is really key for young people. And in that context, though, there's been a green wave in the United States. And as of November 8, 2023, 24 states, 2 territories, and District of Columbia have enacted measures to regulate cannabis for non-medical adult recreational use. As you probably know, in November 2018, Michigan became the 10th state and the first in the Midwest to pass a recreational cannabis law, creating the Michigan Regulation and Taxation of Marijuana Act, with a vote of 56 to 44%. So that image that you're seeing there is actually my actual TV I took a picture of as I was watching the news roll in on election night. And you can see the error there in the rate of voting yes or no. You can see that there's no way that, you know, you could have 178% voting. So I think this is just a really great example of the types of errors we make when cannabis is involved, perhaps the sort of cognitive effects. But as much as I enjoyed that example, this law did go into effect in December 2018, and recreational dispensaries opened about a year later in December 2019. Although cannabis remains a Schedule I federally prohibited substance, which could change any day now, they are looking at efforts to reschedule it. The 2018 law here and the 2008 medical law in Michigan has allowed for increased access and exposure to cannabis throughout the state. You can see here that recreational cannabis dispensaries have really proliferated in our state. And although individual counties or localities that have jurisdiction, they can decide whether or not to allow cannabis facilities in their areas. If you look at this map, you can see dispensaries are quite accessible. And even though youth under the age of 21 cannot enter or purchase from facilities, there's community level exposures, especially to names that sound very pleasant, like Cloud or Urbana, or names associated with appealing foods like cookies, cake, and butter. I literally drove by Butter and I got excited. I thought maybe a new restaurant was opening, and I love butter, and I Googled it, and I was disappointed to find out that it was not an exciting new restaurant for me to try. So, as of January 24, there were almost 2,200 licenses active in our state for cannabis-related business activities, with 762 retailers. That's the population equivalent of putting about 8 dispensaries inside the big house. We also have 330 retailers approved for home delivery as of January 2024. So we can now, as we maybe noticed happening during the pandemic, that now cannabis can deliver to our house just like a pizza. And if any of you have left your homes during the past 4 years, you will likely have noticed cannabis-related advertising throughout our state. Here you can see two side by side that I took in downtown Ann Arbor, demonstrating the dispensary advertising, along with the strategically placed public health messaging. This is one of my favorite examples. Some of these other photos are ones that I took myself. I'm not a photographer, I'm a psychologist. But when you take a look here, there don't really seem to be many significant regulations on cannabis advertising. There are actually some, but they don't sort of hold back the cannabis advertising. Here are just a few snapshots I took in daily life as a person living in the world. The one on the left, if you can't tell, there was a plane flying a banner above Arts, Beats, and Eats in Royal Oak that said free weed at House of Dank. And there was this gigantic billboard next to the stage at the Michigan Lottery Amphitheater where I went to a concert, and cannabis actually was sold there. And then, you know, in the old days, if you went to a concert, lawn seats used to be sponsored by Bud Light or sponsored by an energy drink or something. But the lawn seats at this particular concert were sponsored by Herbology Dispensary. And if you want to go to a football game, game day, Michigan Stadium, that's a thing people around here like to do sometimes. You can literally score some weed on the way to the game. I saw this one on Main Street on, again, a game day at Michigan Stadium. In terms of the cannabis industry, Michigan's seeing over $200 million in sales monthly, with over 30,000 full-time members of the workforce. And so with the state level context in mind, we'll zoom in now on our state. Let's get a picture of how Michigan's looking. Unfortunately, the most recent state level data here are from 2021. The 2022 state level data are not publicly available yet, but 2021 still gives us a good snapshot of what we can be expecting to see here. So in Michigan, about 1 in 4 people used cannabis in the past year, with about 13.7% of adolescents having used. And in young adults, ages 18 to 25, that's 43%. This is important because this age range, the adolescent and young adulthood period, is where the brain is still developing, and cannabis can really have some detrimental impacts, especially continued or heavy use. And when you compare Michigan to the Midwest and the rest of the nation, our rates of use, we are literally higher. In fact, when we look at our use rates in Michigan over time, that's the golden line, we can see that our state outpaces the Midwest and US as a whole, and that leading up to 2019, use rates were increasing locally. You started to see that yellow or gold line go up more quickly than the other lines. And methodological issues in the national survey, again, means that these numbers, we don't have state level reliable data for 2021 or for 2020, I'm sorry. But the 2021 data really show, there are the dots there, that continued upward trend on the right of the graph. And in terms of past month consumption, so past month consumption is what epidemiologists refer to as current use. So in the past month, 18% of our state residents ages 12 and older have used cannabis. And that's nearly actually about 75% of those who used it all in the past year. So that's the thing to keep in mind is people who are reporting past year use, most of them are actually what people would say are current users. Most people aren't dabbling and having cannabis once here or there a couple times a year at a party. They're engaging in past month use, which means their use is probably more recent and more ongoing. So in the terms of the past month use, we had 8% or 8.6% of adolescents and about a third of young adults considered to be currently using cannabis. Here you can see that past month use data broken down by age groups with 2002 up through 2019 in solid lines. And then we jump a year to the most recent data from 2021, which is the set of unconnected dots on the far right. And this is also our first post-legalization, post-methodological changes to our survey, post-COVID onset data. So with those caveats in mind, what you can see is that there's a little signal of an increase post-legalization in Michigan across all age groups. The littlest jump seems to be in the 12 to 17-year-olds, and then we see jumps, a little more significantly in the other age ranges. By and large, the young adult age range, though, they tend to account for the largest prevalence of use, with nearly 1 in 3 young adults having consumed cannabis in the past month. Now that I've given you some context regarding the epidemiology of cannabis and the surrounding industry, we will dive a little more into the drug itself. So here you can see this is a quick pictorial of what cannabis does to the body. THC activates cannabinoid receptors that are throughout our body, those the blue and green dots. And they particularly activate those in the more cognitive and motor areas of the brain, as well as the immune and GI system, and causes many complex actions on our neurotransmitters that affect cognition, memory, motor, mood, and so on. One important thing I want to point out is that you don't see a lot of activity shown in the brainstem region. So with cannabis, we are less concerned about things like respiratory depression leading to an overdose, the way we are with substances such as opioids. And at the same time, we need to be aware that although the lethality of cannabis use is different, there are things to be concerned about with cannabis use disorder, which I'll define momentarily. To understand risk for cannabis use disorder for today's youth, it's important to know more about the products people are using and how they can amplify risk. And to say it pretty casually, today's cannabis is not your mother's Mary Jane. There are a variety of products and modalities for using cannabis. There are many, many new products that didn't really exist before, and they're produced on a mass scale. If you go to a website for a dispensary, you will see a product classification like this one. So in addition to flower or your traditional bud, we now have vaping oils, tinctures, topicals, concentrates for dabbing like wax or shatter, and of course, edibles. And the edible market is specifically interesting because the foods can be packaged in a way that's appealing to youth and adults alike. These are all images I pulled this week from local dispensaries in Ann Arbor. And as you can see, there are a number of products that look like junk food or candy. There are sodas, gummies, chocolate, cookies and cream, peanut butter cups, popcorn, Rice Krispie treats, and even freeze-dried bananas. Another important modality to be aware of are dabs, or highly potent products, which are concentrated butane hash oil. Dabs can look a bit like earwax or rock candy, and they are consumed by pulling off a small piece, maybe the size of a Tic Tac or smaller, and heating it to an extremely high temperature using a specifically designed glass bong, commonly called an oil rig or a dab rig, and then that vapor is inhaled. And dabs are just very, very concentrated forms of THC, and they have been shown to have a number of adverse outcomes. One study found that dabbing can lead to higher tolerance and worse withdrawal symptoms. Vaping is also a newer modality of cannabis use. I mean, typically, this has been around for a while, but it is one of the newer modalities. Vapes involve a concentrate similar to e-cigs or Juuls, although there are also dry vapes that use flower. However, vaping is different than smoking. It does not involve combustion, so it lacks some of the toxic byproducts that accompany combustion. And in some ways, because of that, it's perceived by some people to be safer than smoking. It's noted, however, that vaping usually has greater subjective effects than smoking, and the cognitive and psychomotor impairment tend to last long. However, the modality is similar to smoking in that it's rapidly inhaled into the lungs and reaches peak concentrations and highs in several minutes. Zooming in on vaping, we can see that among those who report past month cannabis use, vaping is occurring at the highest rates among teens. So if you just zoom in on the right, that's among people who are using cannabis in the past month, so they're current users. When we break that down into age group, 55% of the teens who use cannabis, they are vaping. And there are many reasons to be concerned about vaping, particularly given its prevalence among young people. And there's lots of research to be done, given this is a newer trend. But my gestalt here, sort of my, back of the envelope takeaway, is that smoking or inhaling chemicals is generally not the best practice for our lungs, especially our growing bodies. And you've heard me note a few times so far that some of these products have higher potency. And when I say that, I mean the percentage of the product that's comprised of THC. Although the numbers are not exactly directly comparable, you can think of potency as similar to the ABV rating for alcohol. A greater percentage of THC means it's stronger. There are a few papers here that demonstrate how potency is changing in US cannabis. These graphs are from papers that look at the average THC content in cannabis seized by the DEA. So in the 90s, so this is before a retail market, the average was about 4% THC. This tripled by 2014 when the data for the first paper was obtained. And then in a follow-up paper, this increased to an average of 14% by 2019. This is only reflective of DEA seized cannabis, and especially as legalization is now becoming more of a trend, these data don't necessarily reflect the cannabis that is available on the retail market, which can average around 70% for dabs, with some products as high as 90%. Anywhere from 25 to 50% for flower. So I mean it, like when I say that today's cannabis is not your mother's Mary Jane. If you grew up, in the 90s and the cannabis that was available which was street cannabis or, black market, for lack of a better term, that was about 4%. And you can't walk into a dispensary now and get something that low. It is much higher. And a growing literature is beginning to identify the risks specific to high potency cannabis, such as increased rates of cannabis use disorder among people who use concentrates and impaired executive function and inhibitory motor control for those who smoke higher potency cannabis. And by no means is this a perfect analogy, but I thought I'd share the analogy that I use to sort of calculate or think about how strong these different products are. So for example, the flower that was available in the 90s, you can kind of think of that as like a Bud Light. It doesn't have much kick to it. Whereas the flower today is very diverse. It ranges. It can be something like, the strength of a Bell's Two Hearted, which is a higher volume beer, to a glass of wine, to to liquor drinks. Flower is very diverse, different potencies. Vapes and edibles, they're stronger. They are sort of like having a mixed drink. They're your Long Island iced teas of the cannabis world. And dabs and concentrates, that's your Everclear. That's your drain alcohol, your, mountain moonshine. I grew up in Kentucky. And that's the stuff when someone would take it out at the party, you'd say, oh my gosh, no way. I had a bad experience with that, or I know someone who did. And so that's how I think about these products when I want to try to put it in a context that people are more familiar. And the thing that I want to say is that it's really important to know something that we see over and over again in society with drugs of abuse is that when they are made stronger and more potent, we see greater potential for addiction or substance use disorder. And it's critical to note that at the same time, data is a little bit old, but things are kind of only continuing in this path. But at the same time that we are seeing cannabis become more potent, we are also seeing more and more people indicate that they feel there are no harms associated with cannabis use, which you can kind of see in the graph on the left a little bit. And cannabis is overwhelmingly seen as less risky than other substances, there is some truth to that. It is less risky in certain aspects. But what's problematic with that simplified view is that people often associate or think about lower risk as no risk. And instead, what we are actually seeing now is that the potential risks of cannabis are increasing as it gets stronger. So that the views of risk are going in the opposite direction of the actual risk of the substance. And importantly, as a group, young people, young adults ages 18 to 25, with their brains still forming, they continue to have the lowest risk of lowest levels of perceived risk of cannabis use. And as I've mentioned, one of the key risks associated with cannabis use is cannabis use disorder. And I'll make an important point here that is true across substances. The majority of people who use a substance, including cannabis, will not experience major problems related to their use. So most people will not have a cannabis use disorder. But for some people, cannabis can have critical effects due to short-term and long-term or heavy use. And these can include the things that you see on the slide, but most importantly, for my sort of work as a psychologist and for what I see as most common impacts, there's cannabis use disorder or the addiction syndrome related to cannabis use. And a recent meta-analysis showed that across studies, 22% of people who use cannabis have a cannabis use disorder. And when people start using in their teens, their risk is heightened. It's 33% among young adults who use regularly, and there's estimates of between 25 or 50% for people who use daily. Cannabis use disorder is a serious psychiatric condition that involves the continued use of cannabis despite impairment in psychological, physical, or social functioning. You can see the DSM criteria for cannabis use disorder on the slides, reflecting the broad domains of impaired control, increasing priority resulting in social and physical risks, and physiological dependence marked by tolerance and/or withdrawal. In the United States, 27.2 million people have a drug use disorder. 19 million people have a cannabis use disorder. So 70% of drug use disorders involve cannabis use disorder. That's a really large number. And our most recent national data show that cannabis use disorder is prevalent in about 5% of adolescents and about 16.5% of young adults. So that window from 12 to 17, 18 to 25, that's when risk is occurring for the first time and increasing. And you can see that these rates, which cannabis is always on the left in these two graphs, they contrast against substances like prescription opioid pain relievers and methamphetamine, which are arguably more deadly, but less common. And here I previously, actually, so here you're seeing an 11-year period, a stark increase in cannabis use disorder prevalence, with the blue showing 2011 and the orange showing 2022. All of the things that have happened during that decade have included more access via legalization, availability of higher potency products, reduced thinking about the risks, reduced perception of risk, and a mental health crisis. People often want to know, well, how does legalization impact cannabis use? Does it make more people use? Does it make cannabis use disorder go up? You know, we're trying to figure that out as states enact these policies and enact them at different times and in different ways. And so there's this review more recently published by O'Grady and colleagues. And I'm focusing, since I was asked to talk here about adolescents and young adults, on the data for those groups. And in terms of legalization impacts on CUD, on cannabis use disorder in adolescents, there were only 2 studies that have even been done on them, but both of them showed that CUD have increased. There was one study that showed for young adults, and that showed no change. It's a little too early to tell if there is an impact or not, I think, and since there's only been one study. In just looking at prevalence of cannabis use, there's more mixture across the board among adolescents. Impacts of legalization, 10 studies showed no change, 6 showed a decrease, and 7 showed an increase in use. And for adolescents, or for young adults, more studies, 8 showed an increase in use. So this is one of those things that we want immediate answers for, but data is pouring in and we're sort of still grappling with what are these impacts of legalization. But this is the first blush, at least, for y'all to know. And in the legalization context, we are seeing that potency and frequency of use matter with regard to CUD risk. Remember, I showed you that graphic of potency increasing since the 90s. Well, in 1992, lifetime risk for CUD was 9%. Now it's 30%. Vaping among youth, as well as other higher potency modalities, is driving increased concern about these rates. In addition, risk for CUD increases as frequency of cannabis use increases. So more consumption, more likelihood of CUD. And this is really critical because we're also seeing that daily use of cannabis is increasing. Further, co-use with tobacco, one of the other top 3 substances used in the United States, increases risk for CUD and is also associated with more withdrawal symptoms and reduced success with quit attempts. And I mentioned withdrawal a few times. I want to point out this is related to a common myth I hear about cannabis, which is that people believe cannabis is not addictive, that you can't experience dependence, and there's no withdrawal syndrome, that it's natural and it's a plant, and therefore, you know, it's not addictive. There's no withdrawal. Well, that's simply not true. Evidence really supports that the key facets of addiction, tolerance and withdrawal, do occur with prolonged cannabis use. The issue is that the major drivers of withdrawal in cannabis use disorder are mood and behavioral symptoms, as opposed to the more physiological symptoms that we see in the withdrawal syndrome with alcohol and other drugs. I also want to point out that cannabis use disorder can carry risk for several of the comorbidities that you see here. Cannabis use disorder doesn't often travel alone in terms of mental health or other problems. And on the flip, among people who have other diagnoses that you might come across in different clinical settings, there's an increased risk of CUD. If you are treating someone with depression or bipolar disorder or schizophrenia, you probably need to be asking what their cannabis use has looked like, if at all. And in thinking clinically about addressing cannabis use, the U.S. Preventive Services Task Force and others recommend routine screening for cannabis use problems as part of primary care. But one could argue it's important in any clinical or healthcare setting, including school-based health. And good clinical practices indicate that we should be asking patients about cannabis separately from other drugs. So when you go to your doctor, I go in and I fill out my paperwork before they ask about alcohol and drugs. When you ask a patient, do you use any drugs? That really complicates the picture for those who do not view cannabis as a drug, or for those who've heard it's medicine. But in your clinical practice, at a minimum, if someone is using cannabis, it's recommended to assess quantity, frequency, and how they use it or their mode of administration. And obtaining estimates of potency are also useful, as this can facilitate a harm reduction approach. And the packaged THC products that you can get in a recreational dispensary do include labeling of THC potency, although it's estimated. But if you're working with folks, one of the key things to keep in mind is that by asking about cannabis use, you can just start to normalize bringing it up as a part of routine care. Given the inevitability of CUD, I want to also touch briefly on treatment for this condition. There are effective treatments available as described here in a recent meta-analysis and summary of the literature. By far, the best evidence supports that individuals with CUD should be referred to cognitive behavioral therapy and or motivational interviewing or motivational enhancement therapy or contingency management, although this approach is not widely available. There is also limited evidence supporting other approaches, including reliance on mutual help groups like Marijuana Anonymous. In terms of people often want to know, is there medication for CUD? And generally speaking, the state of the literature right now is that there's no one medicine that you can give someone to treat their CUD. This is not the same as opioid use disorder, where Suboxone is a really great treatment. It's not the same as alcohol use disorder, where we can, prescribe other medications. There's no silver bullet for this. Other drugs can be used to ease withdrawal syndrome or can be used to treat co-occurring effects. For example, we should be treating co-occurring mental health symptoms with appropriate antidepressants or other medicines. But there's no drug or pill we can give people to help them with their CUD and make it go away. And the general conclusion, at least, from recent systematic reviews, is that psychological treatments are the best evidence for treating CUD. So if it's happening and you are seeing people in your practice who might be struggling with CUD, the best option is to refer them for substance use treatment and or to trained psychotherapists who use cognitive, behavioral, and motivational approaches, which are quite commonly available in the community. In terms of prevention and early intervention approaches for youth, I do want to highlight a few programs from our team here at Michigan. This is Project Chill, led by Dr. Maureen Walton. This is one of the only effective cannabis prevention programs listed in the Surgeon General's Facing Addiction report from a few years ago. This was a program that was administered in primary care settings to youth ages 12 to 17. It was a 20-30 minute computer program. And administration of the computer program prevented initiation of cannabis use among youth who had never used before. And among those who had used in the past, the program decreased cannabis use related consequences, as well as other illicit and prescription drug use. So there are brief programs that can be implemented that don't require a lot of clinical or staffing that can be effective in addressing cannabis use. In recent work from my team, we also found that an 8-week social media delivered group intervention was promising for reducing cannabis consumption among young adults. And in particular, we reduced vaping by 44%. The commonality about this program and the one led by Dr. Walton is that the information is tailored to the age group. It's tailored for youth and young adults. It does not rely on scare tactics or just say no mentalities, and is guided by a motivational interviewing framework focused on honoring autonomy as well as values-aligned activities. We're very aware of and understanding of harm reduction goals. We, kind of work with people to meet them where they're at. And that is what we've found is helpful in these types of programs that have been effective. And with that, I recognize my time is coming to a close so that we can have some time for me to attempt to answer questions. I don't know if I'll have all the answers, but I do want to briefly sum up what I think are some of the key points from today. Cannabis use and cannabis use disorder is increasing, especially among young people. Access via recreational means is also increasing, especially for highly potent products like we've never seen before. Perceived risk of cannabis use is decreasing at a time when the risks are greater than ever. And really, communities and practitioners need to brace themselves to address CUD, especially as it intertwines with what we know in a mental health crisis in today's world. With that, thank you so much for your attention and your attendance. My email is here on the slide in case people have questions that I don't get to today. And I'll stop sharing my screen now and let folks moderate. Thanks.
Thank you, Dr. Bonart. So before we get to the questions, please notice that the continuing education credit information is on your screen. You can scan the QR code by using the camera function on your phone, or you can click the links below the QR codes to access information about obtaining your credits. And this will also be sent out to all attendees via email. So with that, we will get to some of the questions that were put in the Q&A. So one says, is this data nationwide or just from Michigan? And I believe this was one of your first slides. This question came in pretty early.
Yeah, so data was nationwide until I, got into where I showed the map of Michigan, right? So early data and the talk was nationwide, and then I gave you some local figures. I hope that helps answer that question.
The next question is, do you think that youth are looking at marijuana usage like smoking cigarettes due to it being legal in some states and their first exposure at home?
Do I look at it like smoking cigarettes? I'll speak maybe a little more anecdotally to that in sort of the young people I know. Young people I know have grown up thinking cigarettes are so bad. So I don't know if that's the same now. I think they are much more sort of exposed to cannabis, cigarettes. They know cause lung cancer. There's been so much public health messaging that has been beat into society around that, and less with regard to cannabis. So I don't know if they're looking at it the same way. And I think they may be looking at it as safer again because of even though tobacco was a plant, and I say this, I grew up on a tobacco farm. I actually got my start in the addiction field because I grew up on a tobacco farm. But, I think it's a little bit different. I think that we don't have the same sort of cancer type of risk that people have the same level of concern about. I do think that some are having their first exposure in the home. There are parents, I've been in when I did work more in treatment and we had our adolescent team. I mean, the kids would use with their parents, right? So that's definitely an exposure that, is occurring now that maybe we didn't think as much about many years ago.
Thank you. Next question. Can you provide guidance for social workers in the emergency room setting when youth and their family members present to the ED after using cannabis? Is there any brief information you recommend sharing with them?
Well, so I wish there was just like a one website that you could refer people to that would be really good. Like NIAAA has Rethinking Drinking, and that's always like, something I could give someone to do on their own time. There's not something like that for cannabis. What I would say is that, using resources, to provide education, the National Institute on Drug Abuse does have some educational sort of fact sheets. And I think as social workers, you really just want to use your really great clinical skills and your sort of motivational interviewing skills to provide information that, there are risks associated with cannabis use. Perhaps the biggest being cannabis use disorder, that it complicates mental health treatment. And we know there's a lot of youth out there suffering and their parents with mental health issues, that there's not really evidence that it actually helps mental health. Some people think it does, but there's no evidence to really support that, especially in youth. And so you really want to talk to them about what are other alternatives to address the needs maybe that the cannabis is filling in their lives. And that, I hear you, I do studies in the emergency department. You can't do a ton of that in one visit. So I think you want to plant a seed in a visit like that about risk and where is this person going in life and how will that help or hurt them getting where they need to go. I'm also a motivational interviewing trainer, so I always tend to think from that perspective.
And someone said, I missed what was said about physiological addiction of marijuana. Could that be touched on real quick?
Yes, I will say it's true. It happens. So the physiological aspects of addiction, which are tolerance and withdrawal. And so tolerance is, the physiological sort of craving or need to have more of the same substance to get the same effect. And then withdrawal is when you go without the substance that you feel bad. And that withdrawal or that feel bad syndrome looks very different for different substances, which is, can be life threatening in the case of alcohol, or can be just like the worst stomach flu ever if you're withdrawing from opioids. For cannabis, the physical addiction, you become physically dependent. You're used to getting those chemical, hits in your brain. The withdrawal syndrome, which is the physiological sort of manifestation of addiction and then stopping the substance you're addicted to, that's just, let's say, uncomfortable. It's more mood, it's mental, it's anxiety, it's feeling irritable. So it's not life threatening. No one has to be, hospitalized or, given, necessarily a detox medication. But the physiological symptoms of addiction to THC do exist. And at the same time, they are not going to be life threatening in the sense that other types of symptoms of addiction may be in other substances.
And with the large advertisement on one of the early slides that was at the Michigan Lottery Amphitheater, did you say that they were distributing cannabis at the venue? Their website says marijuana is prohibited.
So my understanding, so I will say I did not walk up to the table where there was cannabis. That's, not something I would do. And there was a booth set up that looked like they were setting up to sell. And I definitely could smell it in the air. Of course, people have been sneaking substances into concerts for, many, many, many years before we had legalization. So I can't speak to whether, what was actually sold, although there was a booth set up that appeared like it would be selling it. And it may be that at certain events they have different restrictions. Maybe shouldn't have said where that was because I can't actually speak for the organization.
And do you know to what extent this research conclusions are applicable and generalizable to other countries outside the US? I'm curious about international comparison of data and findings.
Gosh, I think that's a great question. And, I really, for this audience and for our group focused on our local context. And I personally am not aware of what the comparisons would be across countries. I do know that the Global Burden of Disease Study, so these are things you can Google, right? I'm trying to at least give you some resources. They publish data on cannabis use, and then the World Health Organization may have some information as well. I'm pretty hyper focused on my local community, especially having lived here during the transition into legalization and being a clinician. So we do know in general what drugs of abuse and alcohol, there are different sort of norms in countries. So it's actually something you've piqued my curiosity about, and I might look into seeing what's going on elsewhere.
And can you identify any specific potential effects of chronic use on brain functioning in adolescents outside of lower IQ and memory impairment?
Yeah, so again, I'm not a neuropsychologist, I'll say that too, and I'm always really bad at the brain stuff and remembering what part does what, but which maybe doesn't make me look good in my field. But so the slowing of motor skills, reaction time, impaired coordination, and attention abilities tend to come up with anyone, but with adolescents, what you're doing is you're doing that at a time when that brain is still baking. And so I think there's more of a chance that, you can have some outcomes because of that early formation of problems and early consequences. And especially when it comes down to academic functioning. It's not just school dropout, it is making it harder to think and to remember and to answer questions that use complex skills that you're doing when you're taking a test in school.
Okay, well, thank you so much, Dr. Bonar, for your time today. And with that, we are at time. So thank you to everyone who attended. And if you didn't get the CE or the credit information, that will be sent out to you later. So thank you so much. Have a good day.
Thank you.